Hello and welcome to another episode of Stroke Rounds. Today, in this episode, we will discuss about one of the commonest nemesis of neurologists and neurosurgeons around the world, chronic subdural hematoma. Recently, there is a lot of buzz around the pathophysiology and new treatment option which has come up from chronic subdural hematoma. First, let's see a case. This scenario many of you might have faced in your OPDs and practice. A 75-year-old man, he comes with memory disturbance. He has multiple comorbidities, coronary artery disease, atrial fibrillation, and ischemic stroke in the past. He is a diabetic, hypertensive, he is on antiplatelets and an anticoagulation. You get a CT scan done, you find chronic subdural hematoma with minimal mass effect. What to do next? So what is chronic subdural hematoma? It is not the collection of blood alone. It's collection of blood, fluid and blood degradation products in the subdural space. Recently, a newer terminology has been proposed for it, non-acute subdural hematoma. In chronic subdural hematoma, 10% can have an acute component to it, like in this CT scan. So why is it so much relevant nowadays? The life expectancy has gone up by many miles. So frequent use of anticoagulation and antiplatelet medication. In one of the studies, the incidence is up to 20 persons per 100,000 per year. And it is almost double that of aneurysmal bleeds. And it is expected to double in the next 25 years. Many of you might be knowing it is one of the most easily treatable causes of reversible dementia, but it usually presents with vague, non-localizing symptoms. Traditionally, the blame has been given for the rupture of bridging veins and rupture of small cortical arteries. But is the blame only for bridging veins? Recently, there is a lot of update in the pathogenesis of chronic subdural hematoma. In this picture, you can see the dura has got many layers. One is a periosteal dura, the meningeal dura, and there is a collection of cells known as the Bordal cells. Once there is a trauma, there is a rupture in the Bordal cell layer and CSF is leaking into the dural space. Once the dural space is composed of CSFs, the injured dural cells will release cytokines. This will lead to increase in fibroblasts and other growth factors, which will produce immature capillaries, which will bleed, leading to hematoma formation, which will go on accumulating, leads to more and more of cell injury, and this cycle follows. In histological pictures, you can see neovascularization around a chronic subdural hematoma specimen. So it's not just a tear in the vein as previously thought, it is inflammation with continuous ooze from the immature capillaries is a key pathogenic factor. And this is a deadly chain reaction. We have to halt this chain reaction to effectively treat chronic subdural hematoma. So why is it so much challenging to treat? As seen in the first case, there will be a lot of patients who are high-risk surgical candidates, and some of them will be having smaller asymptomatic STH, but they will be on antiplatelets and anticoagulation. You do a surgery, the patient has recurrences. You don't want to do surgery again. The patient is having an underlying coagulopathy. In all these scenarios, you find it difficult to treat. Although surgical treatment is a gold standard, a new treatment measure has come up. So there are traditionally many methods why you can tackle all these arms. One is ACEIs and statins, which can reduce the inflammation and angiogenesis. You can give tranexamic acid to prevent the leaking and bleeding. You can give dexamethasone to relieve the inflammations. So all these will tilt the balance towards either hematoma absorption or growth of the hematoma. You do surgery, you tilt the balance towards hematoma absorption. You're not doing anything, the symptoms will worsen and the hematoma will grow. In surgery, we are tackling this. The hematoma is growing, you're draining out the hematoma, you get reduction of symptoms. But what about the primary pathogenic factors? How we can tackle it? What if we can cut off the leaking and blood by cutting off the blood supply to to the dura. Middle meningeal artery is a main blood supply of the dura. What if we can obliterate the middle meningeal artery? It can hold the neovascularization, which will allow the collection to be resolved without any recurrence. So the new treatment option that has come up is medial meningeal artery embolization. In next session, we will focus on middle meningeal artery embolization. Please leave your comments and thought in the comment section below. Thank you.